Welcome back, and we're going to talk about skin, hair, and nails today. I thought it would be helpful for me to go over some of the highlights of your readings, and I know that this is an online class, but I thought maybe I could bring some perspective to the skin, hair, and nails section. So with each, as you notice with each of these chapters, you've got a little bit of anatomy and physiology, and then you've got what are the important history questions, and then what's the exam look like. So in the general approach, I talked about using your senses and using your hands. And so what we use for skin, hair, and nails primarily would be inspection and also palpation. Those are the two major senses we're going to be using. So our eyes and our hands to do a good skin, hair, and nails exam. And then also when we come together in our first lab, you're going to be doing a skin, hair, and nails write-up. At the end of this PowerPoint, it does talk about some of the abnormal findings that you're going to see, and they're also in your book. So just going on, you could see that physically that we do have 3 layers of skin. The skin, by the way, is the largest organ in the body, and it has several good uses. The skin is used for protection, for heat, and for hydration. Those are some of the things that we use, and gives our body shape, so things that we use for the skin. We also have what we call epidermal appendages, and that's the hair. We look at the hair. We also look at the glands, and then we look at our fingernails. So those are the 3 areas in this section. So you've got a little diagram of what the skin looks like. It shows you how the hair comes up and where these glands are. That's especially important, I know you all know, when you get into burns and what kind of burns a person would have and how they lose that protection and can lose some of that fluid. You also can see a picture of the structure of the nails and the nail bed, which we always look at the nail bed to see the color of the nail bed and does it have any ridges. And we also look at the angle of the nail bed going into the nail fold to see if the person might have spoon nails or club nails. Those are some of the terms we use. So again, the function of the skin is protection. It's also for temperature regulation and wound repair. Those are some of the things that the skin is used for. So if I have someone that is, what are some of the important history things? Now in this Jarvis, I want to tell you that you have under like health history and other findings, you're going to see, and this is chapter 14 is, chapter 12, I think I said. Yeah, chapter 12. What you're going to find in Jarvis, which I like, is that you're going to find some data on the left side of the page, and then there's a pink column. And I just want to tell you that when you're studying for your test, be sure you know the normals and what's in that pink column. So when you're studying for your test, this is the things you should be thinking about. What would be the subjective data about this exam area? How do I do the exam? What are the normals and abnormals that I might find? And then if I do have an abnormal finding, what would I do with it? Would I document it? Would I refer them on to a physician? What would I do with it? And certainly with the skin, I can look at these health history questions, and I'm already saying to myself, I know that if there's a change in a mole, that could be a sign of what? Cancer. And so if I have a question on the test about what would be most concerning, I'm going to be looking for the signs of a cancerous mole. So here's some other history questions. Does this person have allergies to medications, food, or the environment? And has that caused any kind of skin rash or reactions or swelling? Those would be insignificant. Psoriasis or eczema. Does this person have any kind of dry skin around their joints or any kind of in their hair? Changes in a mole, and I just told you that a mole changes could be significant for cancer, and we're going to talk about that. But there are signs of cancerous or signs of cancer, and it's an A, B, C, D, E type of system, and we'll get into that in a few minutes. Has the color changed in your lesions, or has the person had any kind of change in color? Are they excessively dry or diaphoretic? Diaphoresis means excessive sweating. Any pruritus? Pruritus is a term you all know. It means itching. Is there any itching going on, or excessive bruising? Pinpoint bruising or bigger areas of bruising can be called ecchymosis or purpura. So are those things happening? I also want to know, do they have any rashes or lesions already? And what kind are they? Are they opened or are they scabbed over? What do they look like? What medicine is this person on? That's going to be a clue for skin conditions. Maybe they're taking a medicine like an antibiotic that's caused a rash, or maybe they're on medicine for a rash or for some kind of skin condition. Has this person had any problems with hair loss? Now, we have something called male pattern baldness. That is normal. Or you have some people that pull their hair out. Maybe they have ringworm in their hair that's caused a little bit of alopecia. And alopecia is the word for an area of baldness. Any changes in the nails, splitting, dark hemorrhages, or any clubbing, all of those things can be signs of either malnutrition or lack of oxygen or even cancer. There are some changes in the nails that can be cancerous. What kind of environmental or occupational hazards may this person have been around that would have affected skin or hair or nails? For instance, do they work in an environment that has got chemicals that could cause some kind of rash? Is there any kind of exposure to chemicals related to dishwashing soap or, something their hands might be in? And then what are the self-care behaviors this person has? Now, when I think of self-care behaviors for skin, hair, and nails, I'm thinking about self-skin assessment. So does this person every month, I know you all have heard about breast self-exam and testicular self-exam, but does this person do a total skin assessment every month and have someone look behind them when they can't see their backside, so that we can keep an eye, the person can keep an eye on, do I have any moles that are changing, and that type of thing. The other self-care behavior with skin, does this person use sunscreen when they go out in the sun? And we know that there is a ton of skin cancer going on, and so that would be another thing to think about. Now, after you have done a good history on the skin, the hair, and the nails, then you're ready to examine these pieces. So how do you prepare? You're going to use your eyes and your hands. So adding to that, what about a light? It's nice to have a strong light. It's also nice to have that centimeter ruler. So if you see any lesions or areas of swelling, you can measure it. I like to have gloves just in case there's a lesion that's open on the body somewhere. There are some special procedure lights that you might see. One is a Woods light, and a Woods light is that kind of light that it's almost like a blue light that fluoresces special things. If a person has ringworm or lice, those fluoresce under a Woods light. Sometimes you just need a magnifying glass. And then there are times that we might want to test and see, does a person have a particular kind of lesion, like that they would want to put under a glass slide or use a preparation called KOH, which might make it luminesce. So those are for special procedures. So first thing I'm going to do with the skin is I'm going to inspect and palpate it. But inspect comes first. Now this is something you'll be doing in lab. So you can raise the sleeves up, and I would suggest that you all just wear comfortable clothes that we can look at each other's skin with on the next lab. But pull up the sleeves of the arms, have your patient put their arms straight out and look first at the top of the arms, have them put their arms up and look at the back of their arms. That would be the first step. Then take the back of your hands and touch the skin on the top and underneath, on the top and underneath on the bare skin. That would be inspecting the skin, and that would also be palpating it. Do the same thing with the legs. Have them wear shorts or pull up the gown and look really carefully at the front of the legs, at the back of the legs, and then touch the top of the legs and the bottom of the legs. That is inspection and palpation. Now, for every system that you go through, you're going to still inspect the skin for color and other changes. So I'm inspecting for color. What is the overall color or general pigmentation of my client? And that really is a ethnic or variation. For instance, they may be tanned, or they may be dark or light brown, or they may have other hues of color. So what is their general pigmentation? What you do want to do, and you'll be doing that on the write-up as well, is that you're going to rule out these 4 different color changes. Rule out pallor, which is caused usually from anemia. Rule out erythema, which redness is caused usually from infection. Rule out cyanosis, and you all know that cyanosis is a sign of decreased oxygenation. Or is this a problem with jaundice? And if a person's skin has that yellow hue, they may have either liver or they may have gallbladder problems that would cause jaundice and problems with bilirubin. So those are the 4 different things you're going to be learning about. And in your chapter 12, it talks about more extensively how to look for those, especially looking for those color variations in people of color that have different cultural backgrounds or different ethnic backgrounds. So I've inspected the skin, I've palpated it. When I palpate it, I'm palpating it for temperature. Is it hot or cold? I'm also trying to determine if it is moist. So you can say dry or moist, or diaphoretic, which would be someone that's shocky and sweaty. Or you might see if they're really dry, are there other signs of dehydration, like a dry lip or dry mouth? Those are some of the signs of dehydration. When you're doing your gliding over or touching or with your hands, you're checking the texture of the skin. Is it thick, or does it seem to be even texture? Are there thicknesses or calluses over the hands or the feet? Do you see any edema? And so part of your write-up will also be to check for edema. And where you check for edema is down in the legs. So what you'll do is you will check for, when you're going down and doing your leg assessment, you will be pressing your thumbs against the of the legs, pressing your thumbs against the tibia of the legs for about 5 seconds. 1, 2, 3, 4, 5 against the legs. Then you run your hand over it and you say, do they have edema or not? Now, we know that edema is rated on a scale of 0 is no edema, and then you have edema that might be 1+ or 2+, 3+ or 4+. And if you have 4+ edema, that is called pitting edema. Not only does it stay there a long time, that indentation, but the leg itself is swollen. So we do rate edema. The other thing we rate, and that you will be doing, is called mobility and turgor. Now, mobility is how well does the skin stretch when you pinch it. The pinching it up is the mobility. The snapping back is the turgor. So pinching up is mobility, snapping back is turgor. And for your final performance exam, already I've shown you that you're going to be looking and inspecting the arms and the legs. You're going to be touching for temperature. And you're also going to be pinching a little bit of skin under the clavicle right here, and that is called skin turgor. And as well as looking for these other things. You also, when you're looking at your skin, can say, does there seem to be any abnormal vascularity or bruising? I worry about bruising for a lot of things. Maybe the person has leukemia, or maybe they've just been prone to injury, but I'm going to be looking for pinpoint as well as other bruises. Maybe they have tortuous dilated varicose veins when you're looking at their lower extremity. So if you see a lesion, what are you going to be looking at? Well, if I see a lesion, I'm going to look and see what color is it. Is it one color or is it multicolored? I'm going to see, is it elevated or flat? Now the back of your book, chapter 12, goes through what are the primary lesions and what are the secondary lesions. So there's primary lesions, and primary lesions are usually one color. The elevation, they could be flat, and I always say flat like a mat, M-A-T, is a macule, M-A-C-U-L-E, macule. Or is it elevated, which would be pile, like a pile, and a pile that is raised is called a papule. So it's a pile or a papule. Those are both primary lesions. If somebody scratches a primary lesion and it gets opened and infected, it becomes a secondary lesion. But primary is, could be a freckle, it could be a mole, it could be a wart. All of those are primary lesions. So when I look at lesions again, I'm going to say, what color are they? Are they elevated or flat? And what pattern are they? What pattern? So are they round? Are they elongated or square? Are they just like little spirals? And then what is the size? This is when you take out your tape measure and you measure across and up and down. Where is this lesion? Where is this lesion? Be very specific about the location and where it is on the body. And how is it spread? So what we talk about, so for instance, you'll see some terms like discrete. A discrete lesion is like one like pimple that you see, for instance, or pustule, whereas that would be called a discrete pustule lesion. Whereas if it were like the measles and there's just a bunch of lesions running together, that term for distribution is called confluent. That's actually the configuration, maybe a configuration of confluent. The word con means with, and then fluent means together. So if you hear the word confluent, that lesions are all running together, and you can't see separate ones because they're all running together. So those are some of the terms. And then I also ask, is there any exudate or something coming out of it? Some serum or pustule or something like that coming out of it. All right, we've done the skin. Now let's talk about hair. So hair is kind of easy. You inspect and palpate for color. What color is it? Is it brown? Is it blonde? Is it dyed or treated hair? You also look about texture. So you're going to have to do this. You might want to put gloves on, but you're going to look and say, is it thin texture or coarse and thick? And how is it distributed? That means, is it distributed evenly on the hair? Do you see you can also look on the eyebrows, of course, but we're looking mostly at the head at this point. But distribution, is there male pattern baldness? Do you have certain areas of alopecia, which would be bald spots? And do you see any lesions on the scalp or any infestations? And this is in my world where I'm a nurse practitioner. I do see head lice, and I have seen live bugs. I've seen ringworms. I've seen sores. So the best thing to do is to part the hair in sections and go through every section and look at the scalp. And then the other thing, that's inspection. The other thing you should do is actually palpate the scalp. So put your hands on every part of the scalp. And what are you palpating for? You're palpating for any kind of lesions or masses that you can feel, and then any areas of tenderness that the person might report. So be sure you inspect and palpate for all of these things. And of course, if you see or think that the person, if they think they have a lesion, you might want to put your gloves on just in case you run into something that you're not expecting. Now, as far as nails go, nails are pretty easy also. You're going to inspect the shape and the contour. So you can look across like this and across angled. Look at the shape of the nails. Are they rounded at the ends? Are they rounded over the nail bed? Do they adhere pretty evenly to the nail bed? And then you want to look at the consistency. Are they a consistency that would be, I want to say, thin or thick? Or are they okay? Do they have ridges in their nails? Are their nails misshapen? And then what is the color? And usually you look at the color and you say the nail beds are pink, and then you press on the nail beds and you capillary refill. Capillary refill is less than 2 seconds or less than 3 seconds. Anything over 3 seconds, of course, means you've got hypoxia and poor circulation to your peripheral extremities. When you're also looking at the shape and contour, you want to rule out clubbed fingernails. And of course, clubbed fingernails would be someone with cystic fibrosis or COPD that have had poor oxygenation for a long period of time. So we have this promotion of healthcare and self-care, and I told you we would get back to skin self-exam and also any, what are we talking about? If you find a lesion, you have to ask yourself the ABCDEs. Is the lesion asymmetrical or is it symmetrical? Asymmetry is a sign, a warning sign. Usually the lesions are symmetrical that are not cancerous. What about the border? Is the border regular or irregular? An irregular border is always a sign of a possible cancer, and that's something to be further investigated. Color, ABC is color. The color is, if it's a single color, that is usually a normal finding versus something that is variegated or has multiple colors in it. And then diameter. We always look at the size. Take your measuring tape out. Anything that is bigger than 6 millimeters is considered a big lesion and that needs to be investigated further. And then E is for, is it elevated and enlarged? And we always want to watch and monitor those that are elevated and enlarged. So this is the ABCDE rule for ruling out cancer or for monitoring something that could be cancerous, and it's an important thing. We don't need to look at the special considerations for children, so I'm going to move past that. These are all of the types and shapes and configurations of lesions that are well identified, and you can see these pictures in your chapter 12 of Jarvis. Annular means circular, which would be like ringworm. I already talked about confluent and discrete. You can also see grouped and gyrate. Linear are some others that you might see, which would be like in a line. There are a few pictures here that you have in your PowerPoint showing you the ringworm type. The confluent, they're all running together. Discrete are single lesions that you can identify. And then you have one that says grouped lesions. Gyrate look like almost like little worms. And then target lesions would be targeted on like a particular location. So you might have targeted lesions on the palms or on your feet. There's something called foot, hand, and mouth disease that are just in those areas. There's a linear, you might see a linear lesion perhaps if you've gotten swiped by maybe a poison ivy vine and it's just right down the back where that uroshawl has hit. And then the polycyclic is something else that's just kind of a roundish looking that comes and goes. And then the zosteriform is what you would see with someone with shingles. It goes across that nerve tract, and so there's an identified pattern to that. And I told you that in your book you're going to see what are the primary and secondary skin lesions, and here are all the names for those. So you can look at the most common ones. We have a few here. Macule is flat like a mat. Papule is a pile. A nodule is more of a solid. And a wheal is something like a bleb. When you think about getting a wheal, maybe you get hit by something or an allergic reaction. Now a vesicle is a fluid-filled lesion, and I think of vesicles for someone with, let me think here, a child that might have chicken pox would have a little bit of fluid under it, or maybe someone with exposure to poison ivy might have a little bit of fluid underneath it. A cyst is a bigger mass, and then a pustule is something that's become infected. It could be acne, it could be actually staph infection on the skin. A crust is like a scab, and then scales are more like something you would get with psoriasis. They're kind of silvery-like looking scales. A fissure is a break in the skin, and this is more of a secondary lesion, and as would be erosion and ulcers. Anything that's a break in the skin that could have started as a primary lesion and has become a secondary. And then excoriation, anything that's scratched and breaks open is an excoriation. You all have seen scars, and then sometimes atrophic scars or thickening. So these are all different types that you're going to see. And then there are some vascular lesions that are also mentioned that are in your book. And some of these may or may not be familiar with you. You might see hemangiomas or certain kind of spider patterns, purpura, which means bleeding lesions, or there could be lesions that are trauma or abuse, and we have to be aware of that. And I know we're not talking about child abuse, but we also have elder abuse in our world, and so we know that if there's a pattern injury or bruising where there shouldn't be. So for elderly people, this is showing you a child, but for elderly people, you might see bruises on their arms where they've been shaken, or bruises on their back, or even handprints. I've seen some cases of abuse. So what is the ruling about abuse? If you see something that looks like abuse, you don't have to have it confirmed, but we as healthcare providers have an obligation to report our suspicions of abuse for children and for elders. If you have a woman who is involved in intimate partner violence, you can encourage her to seek help. You can know what the resources are, but that is not a mandatory reporting situation. This is just showing you other kinds of lesions that might be trauma or abuse. Again, I've put the slides in here about children, but we're not talking about children today, so you don't have to worry about that. And then there are some other abnormal skin lesions that you might see, dermatitis and allergic reactions, etc. And then some types of cancer that you might see, basal cell, squamous, or malignant, and skin cancer can cause death, and we need to be aware of it and do some good skin self-teaching for that. And then there are particular lesions associated with AIDS that are also mentioned in your book, particularly Kaposi sarcoma, and some of those lesions and we are working with more and more people that have AIDS. There are some skin conditions also that are considered biological weapons, and anthrax is one, and smallpox. And then we do have some lesions of the hair. So anything from dermatitis, the word tinea is ringworm, and then if you put tinea corporis, it means ringworm of the body. Tinea capitis means ringworm of the scalp. We also have a term that is pediculosis. Pediculosis is a term for lice. And where is that lice? It could be pediculosis capitis or corporis or pubis, which would be pubic lice. So these are some of the terms that you might see that you can review and we can talk some more about later. And then the nail abnormal findings, anything from spoon nails to, I talked about hemorrhaging. Some splinter hemorrhaging can be a sign of injury, but there are some hemorrhaging that can also occur for cancer. So your book talks about that. A patient who is admitted for liver failure will be likely to show which of the following skin changes? You all know that. Jaundice. And the lesions in the illustration are best described as, you got it, zoster-form. So this is the conclusion of just skin, hair, and nails. And I want to just recommend to you again that look at the history data, look at the exam and all the things that can possibly be in the exam, especially in that column where it talks about abnormals. And if you have any questions about this or any questions, please don't hesitate to either email me or drop something in the discussion on D2L. Thank you so much.